but we can go ahead and get started. Once again, welcome everyone. My name is Talia. I'm the Manager of Program Operations at NCSD, and we are so happy to be working with Emily today on this VCA training for you all. So I will just do a brief intro for Emily and then kick it over to her. Before I do though, I have a few housekeeping notes. So while Emily is presenting, we'll ask that questions go in the chat and then we'll get to them at the end of the presentation. There will be a brief break between the presentation and our activities. So you'll have time to go get more water, use the restroom, whatever you might need to do. Today's session is being recorded, so you'll get a copy of the recording after the fact. So if you miss something, don't worry, you can always go back and watch it again. And then also we'll just be launching a brief poll at the end of today's session to gather your feedback about how you think today went. So without further ado, I'm going to introduce Emily and then throw it over. So Emily is the STD Program Manager at the Bellflower Clinic in the Marion County Public Health Department. And Emily is a great friend of NCSD's, and we're very grateful that she is working with us today on this training. So Emily, the floor is yours.
All right. Hi, everybody. Let me get my screen shared. So what we're going to do today is the first half of our training is going to be a learning portion. So I'm going to go over some basic things about syphilis and DIS work, and then we're going to talk about VCA, of course, and then the second half of our session today is going to be a practice session. I hope you all have brought all your materials so that you can practice in real time. But if you're unable to practice in real time today, that's not a problem. Like Talia has mentioned, you'll be able to watch this recording again, and then you'll have my contact information after today. You are always welcome to contact me should you have any additional questions or concerns. Talia and Leo from NCSD will be monitoring the chat for me today since I'm in screen sharing mode. I want to exactly be able to see everything that you might be saying initially, and we will address all your questions towards the beginning of our practice session. So Talia has already given you a nice introduction to who I am. Just to give you a little bit more information about myself. I have been with the Marion County Public Health Department since November of 2021 in Indianapolis, Indiana. Prior to that, though, I worked with the Indiana Department of Health from 2017 until late 2021. I served as a disease intervention specialist for 3 of those years in the Lafayette, Indiana area, managing syphilis and HIV. And then for the remainder of my time with Indiana Department of Health, I served as the subject matter expert for syphilis case management and disease intervention specialist training. I also served on the DIS advisory board for NCSD from 2017 to 2020. And in the fall of 2020, I actually presented at STD Engage, which was virtual at that time, on syphilis outbreak plans and how my state responded to a syphilis outbreak in a rural area of Indiana. I have also received my VCA trainer certification from the CDC in 2019. And my public health education comes from the University of Evansville, where I got my undergraduate degree in 2014. And I currently am 2 semesters away from getting my master's of public health at the University of Indianapolis. So one of the first things we're going to talk about today is the origins of syphilis. The first major outbreak of syphilis occurred in 1495 in the European nation during the First Italian War. 5 million people died as a result of the disease, with each country blaming the other for bringing it across the borders. Though much of the literature from that time points to Christopher Columbus as being the individual who brought the bacteria back to Europe. Girolamo Fracastoro, an Italian physician, was the first person to coin the word syphilis in 1530. In his book entitled Syphilis, or the French Disease, in which he tells a mythos story of how syphilis came to be. Fast forward a few hundred years and a couple of centuries, and we come to the World War eras in American history. American soldiers were returning home from overseas with rates of venereal disease that were not seen again until 1990. Public health spending for the nation was reduced to just $60,000 in 1926, and this paved the way for the worst syphilis outcomes to date. In 1932, the Tuskegee study of untreated syphilis began. 600 Black men were studied from 1932 until 1972. 399 men had syphilis, 201 did not. The men were told they were receiving treatment for bad blood and were given other incentives such as free meals or medical care for their participation in the study. The men who had syphilis were not informed that their ailment was syphilis, and their informed consent was not gathered at any point during the study. In 1972, the Associated Press reported on this study, and as a result, the Assistant Secretary for Health and Scientific Affairs ordered an ad hoc advisory panel to review the study. In October of 1972, the study was ceased as it was determined to be ethically unjustified, with the results of the study not proportionate to the burden carried by the infected men. In 1973, a $10 million lawsuit was filed and settled out of court for the survivors and their spouses. By 1975, the Department of Health and Human Services established the Tuskegee Health Benefit Program, where survivors of the study, their spouses, and their children were entitled to government-provided health and medical care. As of 2022, there are no remaining survivors or spouses of survivors still alive, but 10 children of survivors continue to receive medical benefits under this program. Syphilis rates reached their peak in 1947, just 1 year after the Centers for Disease Control and Prevention were officially established. At the time, syphilis rates were averaging about 500,000 cases or more per year during the World War eras, with case rates twice as high as tuberculosis and case rates 100 times higher than polio. Roughly 18% of all heart disease deaths could be attributed to long-term side effects of syphilis, and about 20% of all institutionalized patients had tertiary syphilis, or what we would call late clinical manifestations today. During the World War eras, about 60,000 babies each year were born with syphilis. Syphilis infections during that time primarily affected heterosexual couples. In 1980s and the 1990s, men who have sex with men became the primarily affected group. The lowest rates of syphilis in modern American history occurred in 2000 and 2001, with about 6,000 cases of syphilis reported each year. This has been the lowest rate of syphilis since 1941. For reference, in 2020, there were nearly 135,000 cases of syphilis. And the two images you see on this slide here are syphilis propaganda material that was distributed during the World War II era to warn American soldiers who were going overseas to not have sex with women that they met, because women were the sources of infection, according to the American government. I enjoy these propagandas because it is a stark reminder of how stigma came from the federal government and how we have learned how stigma impacts STD and STD testing in the modern age. So a brief note on the history of partner services. In the 1930s, the act of contacting sex partners of an infected person was called contact tracing, a term we are all very familiar with at this point in time. When syphilis was endemic in the United States, health department staff members contacted persons diagnosed with syphilis and ensured they were treated, and then they would investigate the sex partners to determine the source of infection. In the 1930s, this service was very beneficial because it created relationships between local health departments and key community stakeholders. It also ensured that newly diagnosed persons were receiving treatment. In the 1970s, partner services evolved to include gonorrhea due to the rising gonorrhea rates of the time. When the HIV epidemic began in the 1980s, partner services evolved to HIV partner counseling and referral services, or PCRS, which you may still hear to this day from some public health folks. With syphilis rates declining slightly in this time period and HIV rates rising, a lot of partner services efforts were focused on communities facing the HIV epidemic. During the 2000s, the syphilis elimination effort was active with the CDC until 2013, when syphilis rates began to hit new rises. As of 2008, the CDC classifies classifies this public health activity as partner services for almost all diseases. We have heard the term contact tracing resurface during the COVID-19 pandemic, but is there a difference between contact tracing and partner services? According to the CDC, partner services is a broad term that describes services offered to persons infected with STD, their partners, and their at-risk associates and social contacts. This service focuses on preventing disease transmission and reducing suffering from disease complications. On the other side of this coin, contact tracing is defined as the physical action of identifying and locating sexual partners to refer them for care and treatment. With these definitions in mind, the difference you could note between these two terms is that partner services includes broad social service actions, such as going beyond the direct sexual partners to find associates and social contacts, whereas contact tracing focuses on direct exposures and referring them to care. In partner services, we also conduct extensive case analysis, whereas contact tracing may not engage in such extensive analysis. I wanted to highlight original interviews as part of this learning session. To conduct visual case analysis successfully, we have to have been able to conduct a thorough and meaningful original interview with our infected patient. Without an original interview, visual case analysis becomes difficult to complete. It isn't impossible because we may have means to gather information through electronic medical records, hospital reports, or past interviews, but not having a current interview will make the task a bit more difficult to complete. Now, we all have experienced this. Getting patients to agree to interview has become difficult as the years go by, especially in the face of the COVID-19 pandemic. Many patients have had syphilis multiple times before, and they don't want to participate in the disease intervention process again. Some patients hold fear about government entities contacting them about their health information, or feel angered that their STD information is known to a government worker. Some patients may be nonchalant altogether, not understanding their responsibility to receive treatment and to inform their partners of this exposure to disease. Conducting an original interview can sometimes feel like finding gold at the end of the rainbow. So when we do get a patient who is cooperative, we want to maximize our time with them to get as much information as we can. Something I wanted to highlight in this section was the practice of applying some basic public health theories to our interviewing work to collect meaningful information from the patient. But most importantly, these public health theories help you spark the change process within the patient and possibly motivate them to divulge information about their sexual network. The health belief model and the theory of reasoned action and planned behavior can show us a framework in which patients are making health-related decisions. And the trans-theoretical model helps us understand how patients move through health-related change. Understanding these frameworks can aid us in disease intervention, and we can listen for cues of resistance, find the pathways that invigorate the patient to feel motivated to change their behaviors, and debunk social or societal myths that the patient may hold. For the sake of time today, I won't be diving into these theories, but please feel free to contact me outside of this training if you want more information about these public health theories. The next item I want to go over is narrative listening. Storytelling is a meaning-making process. When someone tells us a story, they are choosing what details they want to include, what experiences they want to share, and they are also reflecting on what the events meant to them. We tell stories to make sense of ourselves and our world. So when we do have a chance to get an original interview completed, we really want to listen to our patient's story and we want to search for the meaning in their stories. Sometimes a patient's story can draw your attention to information that may be critical to their care. For the moment you're in the interview, shift away from the symptoms or the STD itself and focus on the whole person sitting in front of you. This connection will help you build rapport and extend empathy to your patient. Active listening skills are an inherent part of narrative listening. Once you invite your patient to tell their story, you must demonstrate that you're hearing them. Active listening actions typically involve things like maintaining appropriate eye contact, showing interest in the story with nodding or positive affirmation, asking open-ended questions to encourage the patient to continue, and choosing language that offers validation and visibility. On the subject of language, listen to what phrases, slang, or metaphors your patient is using to discuss their sexual practices. Are there any hints about health beliefs or behaviors in those language choices? Use your critical thinking skills in the moment to pick up on new meanings. I'm going to share a couple of real-life examples with you of how narrative listening was applied to a patient case and ended up saving patients' lives. An older adult with renal failure was speaking to his social worker about end-of-life care. While telling his story, he shared a photograph of his two cats. He mentioned that one of his cats had died a hard death in a veterinary clinic, while the other had an easy death at home. By sharing his feelings about his pet's death, he revealed his personal fears about dying in an inpatient setting. The client's story allowed the social worker to tailor his care plan to meet his needs and his values so that his hospice care occurred in his home and he had less fear of dying. The other story I want to share with you is that a woman talked to her physical therapist about the recent fall she was having. Her story was chaotic and almost incomprehensible to the physical therapist, and she struggled to pull together a coherent account of her recent falls. However, the physical therapist listened intently and let the patient continue with her story. Towards the end of the story, the patient made a strange comment that she had a feeling of something accumulating in her brain. The therapist shared this comment with the rest of the patient's care team, and the patient's neurologist was able to order more testing. It was discovered that the patient had a chronic subdural hematoma, which required immediate surgery. The act of narrative listening saved this patient's life. One of the lessons we're going to get into before we jump into information about VCA is notes on partner elicitation. So we can complete a VCA without partners, but a VCA without partners is kind of like movie popcorn without the butter. It's edible, but it's not really doing that much for us. And we may even question why we bought it in the first place if it's not going to come with the movie popcorn theater butter. Partner elicitation is a hallmark of disease intervention specialist work. It is this action of identifying sex partners, getting them tested, and offering treatment that embodies the public health mission. It is why the DIS workforce is considered the backbone of public health. If we do not have a trained workforce with capable social skills and the ability to blend into communities and be accepted by gatekeepers, our nation would be overcome with transmittable disease. It is your ability to get people to spill the tea, so to speak, that keeps our nation healthy from STD. To successfully conduct visual case analysis and to have successful identification of source and spread relationships, and to meet the mission of disease intervention, partners must be elicited from the original infected patient. Interrupting the chain of transmission happens when we reach sexual partners before they have developed symptoms of disease. This is called primary disease intervention. The name first methodology is the model that the CDC recommends DIS adhere to when collecting sexual partner or syringe sharing partner information. The foundation, which you see on the left side of your screen today, collects our patient's number of sex partners or syringe partners in the interview period, the behaviors they engage in, such as the type of sex or how are they sharing needles with somebody, and where they have sex or where they share syringes with others. And then you'll notice on the right side of the screen, we have 5 main categories of data collection. This is the name of the partner, the sexual or syringe exposure information, the locating information of the partner, the clustering opportunities that are present, and lastly, the physical description of the partners. And you may be asking yourself, why is it called the name first methodology? This is because if our time is limited in an interview, which it can often be either due to our own time constraints or due to the patient's time constraints, We want to collect the names of the partners first in order to build the sexual network. You can always conduct a re-interview to gather information that you may have missed, but getting the names first allows you to build the sexual network and allows your disease intervention team to start recognizing people or patterns of disease, which enables you and your team to provide targeted services to specific groups or areas. Okay, so we are finally on to the good stuff. I appreciate you learning with me or refreshing on some of your history lessons. I find that it's easier to buy into completing visual case analysis when you can view it as a key component of public health action in your disease intervention process. My ultimate goal is to help you feel like VCA is a critical part of your work and to enjoy the task of the mystery solving game, rather than viewing it as a tedious task that you just need to mark off a checklist. Check out the example VCA on the slide here. Who else but a DIS could look at this, translate it, and then be able to return a story of infection? VCA is a coded language that only a few people understand. And in my opinion, knowing how to complete a VCA by hand will give you an edge in the disease intervention field in the coming years. Since our skills are translatable to a variety of diseases, your ability to draw a visual framework of infection networks could help end an outbreak of disease in your community. Simply put, VCA is an epidemiological tool for partner services providers to analyze a case, to determine what and where disease intervention needs to occur, and to determine the most likely story of transmission, and to create a plan of action for future tasks. It is a visual framework that is initiated in the post-interview analysis step of the case management process. It is a tool used to systematically document the social, epidemiological, and medical information of your patient's syphilis infection. A VCA allows you to compare information about related cases to determine if commonalities exist, to highlight informational gaps or conflicting information, and presents evidence to verify source-spread relationships. There are some key components that we need to be aware of prior to conducting visual case analysis. Out of these, one of the most important is the duration of stages of syphilis and their symptoms. Because the rules of conducting visual case analysis are based on the natural history of syphilis, we need to be familiar with the minimum, average, and maximum durations of the incubation period and stages of syphilis and their symptoms. Knowing the minimum, average, and maximum durations of syphilis stages and their specific symptoms will enable you to determine if your patient's story of disease transmission is truthful. Our patients may like to lie to us, but syphilis never lies. It's why it's my favorite disease. The basic assumptions and criteria for related cases provide us with information in order to make the most informed decisions about disease transmission, and it is based on the natural history of syphilis. The ghosting hierarchy provides us a framework to conduct ghosting, or a technique that helps us identify source and spread relationships. So on this slide, there's a chart that showcases the minimum, average, and maximum durations of the incubation period and different stages of syphilis. Remember, an incubation period is the time frame that starts once a person has been exposed and ends when they develop their own symptoms. A latency period is the time frame in which a patient has no active signs or symptoms of syphilis, but is still considered infected if they have not been treated with penicillin. Knowing these durations of time will aid you in making an informed and educated decision about your patient's disease history. For example, perhaps during the original interview, your patient says their body rash lasted for 4 months. Based on the natural history of syphilis, you know that a generalized body rash typically does not last more than approximately 6 weeks. So your patient's rash may not be syphilitic after all. This changes the way we look at source spread relationships of this patient as well. You will also notice that as we add together the maximum durations, our final outcome is the interview periods we abide by for stages of syphilis. We begin the interview period prior to the onset of symptoms in order to maximize the time frame in which we are looking for partners. For example, in primary syphilis, our interview period of 4 months and 1 week comes from adding together the maximum durations of the incubation period and the maximum duration of an untreated chancre. In secondary syphilis, our interview period of 8 months and 1 week is derived from adding together the maximum duration of the incubation period, the maximum duration of an untreated chancre, the maximum duration of a latency period, and the maximum duration of untreated secondary symptoms. You will have a copy of these slides if you have not checked your email. It should be sitting there for you. I have color coded this here to help you visualize how to add together maximum durations in order to get your interview periods. The basic assumptions and criteria for related cases helps keep us on track for constructing the most logical and informed course of disease transmission. The criteria for related cases tells us that cases that are being linked together must meet the following. One sex partner must be infectious at the time of sexual contact. Primary chancre sites must be compatible with the type of sex reported, and that there must be a reasonable course of disease. For example, a partner must have a chancre, mucus patches, or condyloma lata during sexual contact for transmission to occur. A primary chancre on the penis means there was a sex partner with a primary chancre in the vagina, rectum, or mouth. And the disease progression must make sense. If a patient reports developing a chancre 3 days after sexual contact with a one-time partner, that partner is unlikely to be the source of disease. The basic assumptions enable us to conduct ghosting, or the technique used to attempt to find the source and spread relationships. The basic assumptions tell us that syphilis is acquired from someone in the primary stage of disease at the time of sexual exposure, that the patient had a 3-week incubation period, or 21 days, that the patient had a 3-week-long chancre, and that the patient had no more than 4 weeks in their latency period between the primary and secondary stages of syphilis. What you'll notice about the basic assumptions is that they follow the average duration of stages and symptoms of syphilis that we just covered. By using average durations during ghosting, especially on patients who have no verified signs or symptoms of syphilis, we create the most logical story of disease transmission based on the natural history of syphilis. So ghosting, you heard me mention that a couple times now, is a term that is used to describe the act of finding source spread relationships within the visual case analysis, especially as it relates to partners who have no verified signs and symptoms of syphilis. Ghosting combines symptom information from your original infected patient and the basic information about typical syphilis symptoms, and it helps you develop a reasonable course of disease for the sex partner who does not have symptoms. This enables DIS to create a likely source spread relationships in the absence of confirmed signs and symptoms. Ghosting plays a critical role in disease transmission stories because syphilis symptoms are often of short duration and frequently go unnoticed by the infected person. Ghosting allows DIS to identify time periods where more intense disease intervention should occur. For example, through ghosting, you determine a partner was likely exposed to syphilis in January, but they had not reported any sex partners to you during that time. With this new information about disease transmission, you can conduct a re-interview and inquire about sex partners during the month of January. Lastly, ghosting gives you, the DIS, evidence to present to an original patient who may not be truthful with you about their partners or exposures. Syphilis pathologically tells the truth. We know for a fact when people develop chancres after exposure, and we know for a fact when that means they were exposed by a sex partner. Seeing this evidence physically in a VCA and showing it to your original patient may encourage them to tell you the truth. So, since ghosting is the act of finding the source and spread relationships, the ghosting hierarchy exists to guide those decisions so that they are the most informed and accurate. The best disease transmission story will be created when there is an existing primary chancre on our original patient or a sex partner. The second best story can be created from recall of a historical chancre. And we should always try our best to have patients recall symptoms on either themselves or a partner, because this gives us the best opportunity to identify the timeline of transmission. Knowing when people have their primary chancres also gives us an opportunity at finding the disease network and stopping the spread of syphilis before others develop signs and symptoms. You can find source spread relationships by using a ghosted primary chancre or a chancre that the DIS is making an educated guess about. A ghosted chancre is one that is not confirmed or denied by a patient or sex partner, but is estimated to have occurred based on the natural history of syphilis and what we know about disease transmission. This produces a logical disease transmission story, but it may not be as accurate as stories based on existing or historical chancres. Creating source spread relationships from secondary symptoms is not impossible, but it is difficult to do. This will almost always require us to accept the average duration of stages is what each patient or partner went through, so this may not produce the most accurate story of disease transmission. Ghosting from a secondary symptom requires a lot of educated guesswork, and therefore is not preferable to conduct visual case analysis with. However, if it's the only symptom you have, it's a good place to start. Source spread analysis combined with ghosting helps determine missing or conflicting information in sexual exposures, identifies time periods where disease transmission likely occurred, helps you determine which intervention activities you should focus on, and also helps you create the source spread hypothesis of your original infected patient. This analysis typically occurs after partner follow-up has been initiated, and it is the DIS's chance to present a story of disease transmission to their supervisor, their peer, or to another public health agent. You are developing the how and why while documenting the who, what, when, and where of that story. A source is defined as somebody who is an infected person who transmitted disease to an uninfected person. A spread is defined as an uninfected person who acquired disease from an infected person. This can get a little complicated sometimes. Patients can be both sources and spreads at the same time. For example, Johnny had the primary chancre. He had sex with his girlfriend, Heather, who then developed a primary chancre about a month later. In this scenario, Johnny is Heather's source, and Heather is a spread from Johnny's infection. We conduct a DIS investigation, and Johnny named Samuel, another partner he has sex with. Through visual case analysis, we were able to determine that Samuel was the first person to have a chancre, and he infected Johnny, making Samuel the source of the infection and Johnny a spread from Samuel's infection. So, through visual case analysis, we have determined Johnny's source of infection and who he spread his infection to. Source spread analysis narratives can largely be broken down into these key pieces of information. First, we need to identify the critical period of our original patient, which is the time frame we believe our patient became infected or could have infected somebody else. Then we need to identify which partners fall into this critical period. After we've done this, we need to identify who we believe is the source of our original patient's infection, and then we need to identify who we believe our original patient gave the infection to. This is then justified using the evidence you have gathered over the course of the investigation. This could include the ghosting you've completed to determine the story of disease transmission. It could include partner outcomes, so what was their testing and treatment statuses. You probably have interview notes that you will likely refer to for your evidence. And finally, upload or document your VCA as it is required by your jurisdiction. This is an example of a source spread analysis using our previous scenario that we just went through with Johnny and Heather. Now, of course, this is an ideal public health scenario. Real life probably does not happen like this for most of us. Your source spread analysis may be shorter or longer than this, or you may need more details or descriptions of evidence. You should take the time to review your jurisdiction's policies on interview documentation to make sure you're meeting any documentation requirements or any requirements as your supervisor or director may want them. And remember, as a DIS, documentation is your friend. Your source spread analysis informs your DIS teams and your surveillance staff of the disease networks in your community. Thorough and well-documented source spread analyses lead to well-done disease intervention. Source spread information is also what you would share during times of syphilis outbreaks to the Outbreak Preparedness Coordinator or outbreak surveillance teams. It is critical you practice the skill of source spread analysis, even if you aren't doing a VCA, so that you can offer informed disease transmission opinions that further your agency's public health mission and accomplish the goal of primary disease intervention, which I described to you earlier as we want to reach people before they develop symptoms of syphilis. And you'll notice I've color-coded this again. So in case you want to go back and refer to these slides as you're working on VCAs, I've given you color codes here, and then I've color-coded that information here as well. So that way it helps you kind of separate and keep in mind what those key pieces of information are. So now that we've gotten a lot of good background information about some of the skills we're going to apply today in VCA, I wanted to talk to you about the 7 key pieces of information that we put into a VCA chart. You'll see on the bottom left corner here, we have an example of the VCA Pocket Assistant. This is a handy dandy little tool that can always help us remember what we need to put on our VCA. I am 7 years deep into my STD prevention career, and I still rely on this little guy. I have highlighted the first 4 items that the slide covers. So you'll see on our chart here, we have the months of the year, the patient name, the reason for examination, and the medical history. And on the next slide, we're going to cover symptoms, critical period, and exposure dates. First, we always document the months of the year in the uppermost row of boxes here at the top of the screen. We always start on the right side of the boxes. So always come to the end and count backwards to the 3rd box from the right side of the page. So we go 1, 2, 3. Here's our 3rd box. This box is where you will document the current month or the month where your patient got testing and treatment in case you're completing a VCA at a later date. Using our past example of Johnny and Heather, our current month was March of 2020, which is why the 3rd box from the right has the number 3 in it to represent March. In the boxes following the 3, we put 4 and 5 to represent the months of April and May. You will see that I have CY beside these months, and that is to indicate that it is the current year. So what comes after May? Well, June. But where do we put the rest of our months since we have now run out of boxes on the right side of the page? You will see we go now to the left side of the page and we continue putting in the months of the year until we reach all 12 months. You will notice that these months here have LY or last year next to them. And that's because this portion of the VCA up until December represents last year. We need space to do our VCA because we always focus on the time period before our patients develop symptoms. So in order to give ourselves plenty of time to see the history of transmission in this patient, we always put the current month at the end of the VCA so that we can focus on the periods prior to symptomology. So once we have our months labeled, we add in the name of our patient, and we also put in the reason for exam. There is an official list from the CDC called the Method of Case Detection that your jurisdictions may want you to use. Some of these reasons could include screening, self-referral, patient-referred partner, health department referred partner, or cluster related. In our example, Johnny was a self-referral due to him noticing the sore on his penis, which is why we have listed self-referral here. After we have documented our patient's name and our reason for exam, we will start writing in the patient's relevant medical history. Items that should be included would be any past syphilis testing in the previous 12 months, whether reactive or non-reactive, any past HIV or chlamydia gonorrhea testing results, and any treatments given to the patient for STD, or treatments that incidentally treated syphilis, such as a person receiving doxycycline for a different infection. We are also going to include our T-bar, or our treatment bar, as part of documenting the medical history, but more on the treatment bar in just a moment. In our previous example, we didn't specify if Johnny had any relevant medical history, but for the sake of showing you how to do this documentation, I have added in some non-reactive syphilis testing for the previous year. You will see medical history goes on the line labeled history. So we have drawn an arrow, and we have pointed, and we have also written the date. You can see we have our T-bar coming off of this history line as well. You will also see that the history line is divided by tiny slashes. If you look to the left of the chart, each slash represents 1 week. For example, the start of the box means day 1. The next slash means day 7, and then day 14, day 21, and day 28. So yes, that means as we move farther along the VCA chart, day 28 and day 1 will often share the same line. You don't necessarily have to document these numbers on your VCA while you're working. However, if you're new to VCA, it may be beneficial to remind yourself of how time is divided along the history line. Now let's go back to our treatment bar, or T-bar. This is a critical piece of your VCA as it acts as the anchor point for your original patient's infection. In our previous example, Johnny was tested on 3/8/2020. We draw a big T around the day 8 in the month of March. So if we know that first slash right there is day 7, day 8 is just after that, we have a nice big bold T there. On the top of the T-bar, we put the date the patient was tested. To the left of the T-bar, we document the stage of syphilis we currently believe the patient is in. To the right of the T-bar, we document the patient's testing and treatment information as we know it. So let's pause for a moment. All of the information we are currently looking at on this example VCA is numbers 1 through 4 of our 7 key pieces of information. And you'll notice that we have documented everything in a black ink or black pencil, and that correlates with the color of the numbers next to our facts. So this will just help you to remember, when do I use the colors? When do I use red? When do I use blue? You can always refer to your VCA Pocket Assistant to know which colors to apply to what fact. And so now we're going to look at how we document the remaining pieces of key information. So this would cover our symptoms, our exposure dates, and our critical period. To indicate symptoms on a VCA, We draw a red rectangle for the length of time the symptom was, and then we label it with the appropriate label. For example, our scenario with Johnny and Heather is that Johnny had a chancre for 3 days prior to coming to our clinic. So that chancre was projected to have began around 3-5, which is why we have our red rectangle here starting around 3-5 and going up to the date of treatment. We have also listed PENLX, which is an abbreviation for penile lesion. The CDC Partner Services modules have an abbreviation sheet for penile lesion, vaginal lesion, et cetera, et cetera. If you would like a copy of that, we can certainly get that to you. You can also use whatever documentation or abbreviations you're familiar with in your jurisdiction. The next thing we document after we have documented symptoms is the critical period, or the time frame in which we believe Johnny was exposed and became infected. Because Johnny has primary syphilis, our critical period is 90 days, or the maximum amount of time the incubation period could have lasted. To help anchor our critical period, we will also be adding designations of the 10-day, 21-day, and 90-day marks. This will give us visualizations of the time periods where Johnny was most likely exposed to syphilis. This is when we take our blue pen or pencil and we draw a blue line on the underside of the history bar. And we start at the date of treatment and we go backwards 90 days from the date of the onset of the symptom. So for our patient here, we count 90 days backwards from March 4th, which takes us to December 5th of the previous year. You can count on the VCA. So if our symptoms started here, we can go 1, 2, 3, or since you know each slash represents 1 week, you can count back the appropriate number of weeks or days to reach 90 days. When we're at our 90-day mark, we draw a triangle that faces toward the T-bar. This is our anchor and indicates to us it is the beginning of the period in which we believe Johnny was exposed to syphilis. Our next task is to place our 10-day and 21-day marks. We count back 10 days from the onset of the symptom, which takes us to 2/24. We place another triangle here and we point it in the opposite direction towards the 90-day mark. And then we count back an additional 11 days from that 10-day mark to create our 21-day mark. This is the time period, the 21-day mark is the time period which we believe Johnny was exposed. This is our average duration of incubation. However, please do remember that not everybody develops a syphilis chancre within 21 days of being exposed. That is the majority of the time for most people, but Johnny could have been exposed all the way up until December, and this entire time period we can consider for him, we can consider his exposure. Lastly, once we've done all this good stuff and we have partner information, we need to add sexual exposure information. You see there's a dotted line here that's just under history, and there's another line for a partner that matches this one and is right above that medical history. This is where you would show sexual exposure information. We don't actually have a partner documented here, but I wanted to show you how you would document sexual exposure history. Okay, so let's pause. I saw a lot of chats pop up. And if we have any questions about the information I presented, I would love to take some of those. I'm sorry, Marissa, I can't make it any larger, but you should have a copy from Talia if you need to look at a bigger version.
So the blue arrows, those are from the VCA Pocket Assistant. That is from the incubation period?
Yes, you are correct. So the blue arrows represent our 90 21, and 10-day marks. So let's go back to this slide here.
Would that be the same for a secondary sore, or we always just start with a primary sore?
We always start with a primary sore. So based on our basic assumptions, we always start with a primary sore because our basic assumptions tell us that people acquire syphilis from others when they have a primary chancre. Now, you all are educated and you're smart DIS, so you know that there are infection symptoms of secondary, but for the sake of the training today, we're focusing on the primary chancre. And so to expand on that question you had about the triangles, those represent the minimum, average, and maximum durations of the incubation period. So the minimum amount of time somebody could be exposed and then develop their own syphilis chancre is 10 days. The average amount of time from once somebody is exposed to developing a chancre is 21 days. The maximum amount of time from the time somebody is exposed to when they develop their own chancre is 90 days. And we want this information because it tells us this is likely the time period that our patient was exposed to syphilis. So it helps us focus on what sex partners did you have between December 5th and February 24th. And these triangles represent our maximum, average, and minimum durations.
So I have a question. I have a patient, like, he has secondary symptoms and doesn't recall any primary. Would I just use this chart to estimate when I think his primary was?
Yes, ma'am, you would.
Okay.
Yes, you would. So we're actually going to get into that in our practice session.
Okay.
So we will actually go over that very scenario you're talking about.
Okay.
Okay, let me look here. Does anybody else have any questions or thoughts that you would like to address right now before we take a break? I'm not hearing any additional unmutes, and I'm also not seeing anything pop up in the chat. So we're going to take probably about it's 2:54 now. So we'll go ahead and take a break until 3:05. While we're taking a break, please get your items set up. So you will need a VCA chart. You will need a copy of your VCA assistant, which Talia has dropped in the chat for you. You will need your colored pens or pencils, and those include black, red, green, orange, and blue. And Talia will also give you a copy of the VCA exercises we're going to be going over. I will screen share those exercises at first so that we can read them together. But then once I transfer my camera to practicing, you will need to look at those exercises on your own. All right, so please take a break. We will reconvene at 3:05. Okay, everyone, we are concluding our break and we are going to be moving on to the activity portion of our learning session today. Initially, I'm going to share my screen and we're going to review the practice exercise 1 together. And then I will be unsharing my screen and transferring back to my video to start working on this with you. Again, if you can follow along in real time, I highly encourage you to do so. But if you're not prepared to do that today, that is okay. Come back to this training and practice in your own time. So Talia has shared the exercises via email and in the chat. So if you don't mind, please go ahead and get your practice exercise 1 open. And right now, we are going to go through this practice exercise together, and then we will start to do the VCA in real time. So Carmela came into our STD clinic on 3/28/22 due to a lesion present on her labia that was not showing any signs of healing. The lesion had been present for 12 days before she came into the STD clinic. Upon physical examination, the physician describes the lesion in Carmela's medical record as indurated, reported as painless, and located on the left labial tissue. The physician conducts a brief sexual history questionnaire with Carmela and then determines that syphilis testing needs to be ordered. Carmela agrees to have syphilis, HIV, chlamydia, and gonorrhea testing done that day. During the appointment, Carmela reported to the physician she tried using a corticosteroid cream on the lesion but had no relief during the previous 12 days. The physician suspects that Carmela has primary syphilis due to her symptom presentation and orders bicillin treatment to occur the same day. Carmela's test results come back from the lab the next day on 3/29/22 and were as follows. She had a reactive RPR of 1/32, a reactive treponema pallidum EIA, a negative HIV-1 antibody, and a negative chlamydia gonorrhea NAT test. Carmela also received bicillin 2.4 million units, 1 dose on 3/8/22. She schedules a future appointment to have her RPR drawn again in 3 months. Upon further review of Carmela's STD history, it is discovered that she had a negative HIV rapid test and a negative chlamydia gonorrhea urine screening on 11/12/2021. Her reason for testing at that time was annual screening with her reproductive health physician. During that visit in November, Carmela reported to her physician that she has sex with men exclusively. Carmela reported participating in vaginal and oral sex with her male partner. She has reported 1 male partner in the last 3 years, a boyfriend she has been living with recently. She feels safe at home and she does not believe there are any additional sex partners in their relationship, and she is not currently pregnant. So our first exercise is to plot the facts, including the critical period of Carmela's syphilis infection, onto our chart. So I'm going to stop sharing my screen. And what I need you guys to do is, if you hover over my name, go ahead and hit those 3 little dots. And what you're going to want to do is pin my video. And when you pin my video, it should take up your whole screen so you can see me work on the VCA. Now, I must admit to you that my camera is not the best, so it does look a little blurry here. I will do my best to make sure I show you all up close what I'm working on and what we're doing. So I really apologize. I have such a bad camera. All right, my friends. So what we're going to do is, first we need to make sure we have our VCA chart. We have our colored pencils here. We've got our pocket assistant if we need it. And we also have a copy of our exercise beside us. Our first task is to plot our facts. So if we remember from our presentation, our 7 key pieces of information are right here on our VCA Pocket Assistant. So we're going to plot this information about Carmela. So the first thing we need to do is we need to add our months of the year. Carmela tested in March, so that means I'm going to go to the 3rd box. And if we remember, we count, we go 1, 2, 3. We're going to place a 3 here. Then we go 4, 5, 6, 7, 8, 9, 10, 11, 12, 1, 2. And now we have all 12 months on our VCA. If it helps you, you can say CY and you can say LY so that you remember, or I'm sorry, that wouldn't be a last year. This would be a last year. If it helps you remember that the time period has changed, you don't have to, however. The next item on our plotting the facts is once we have our months listed is that we need to document our patient's name and the reason for their exam. So what we're going to do now is we come up here to this section where it says patient and reason for exam on our VCA. And so we're going to write Carmela. And she came in because she had a chancre present on her labia. This is a self-referral. So we've taken care of facts 1, 2, and 3. Now the next thing we need to do is we need to plot our medical history. So if you go back and you look at your practice exercise, we were told that on November 12th, so that would be about right in the middle here because this is 7 days, 14 days. So right in the middle here, Carmela had negative HIV and she had negative CTGC or chlamydia gonorrhea screening. We're also going to write the date there. It doesn't have to be pretty. This is for you all. Okay, great. Talia is helping you all get the video done. Okay, great. Yeah, please pin my video. That way it takes up your whole screen. Okay, so we have some of those medical facts now. I'll bring that closer so that you can see that. So you can see we have negative HIV, negative chlamydia gonorrhea with the date that that testing occurred. The other relevant medical information for us would be Carmela's treatment and her syphilis testing. So that's when we are going to develop our T-bar. We know that Carmela was tested on the 28th, and if we remember, the last line represents the last day and the first day. So our T-bar is going to go right here. We're going to make that nice and bold so that it stands out to us. We're going to put the date Carmela was tested. We put that on the top of the T-bar. Let me bring that up for you all. Okay, so there's that. And then on the left side of the T-bar, we put the stage of syphilis we believe Carmela to be in, which is primary or 7-10. The next information we document on the right side of the T-bar here will be her RPR results. So she had an RPR of 1 to 32. She had a positive EIA, and she got BIC 2.4 times 1. It isn't revealed in this exercise, I don't think, but Carmela, oh, it is. I did put it in there. She had a negative HIV, so we can write that off to the side, and a negative CTGC or chlamydia gonorrhea testing. I'm hoping you all will be able to see that. Let me pull that up for you. So that's what our T-bar looks like. We have our pertinent information there. So that takes us through facts 1 through 4. So we've done the months of the year, the name of the patient, the reason for exam, and her relevant medical history. You don't need to include information that's not relevant to the STD infection. The next thing we're going to do is document symptoms. And that means we grab our red pencil. And if you remember, what we do is we draw the duration of the symptoms. Carmela said her lesion had lasted for 12 days prior to her coming in. So that means the onset of her lesion was March 16th. My red box is going to start here because she had her lesion while she was in clinic. And if we know this is day 14, day 16 is right around here. So now we have our symptom box. We're going to document it as VGLX, or vaginal lesion. Checking the chat. Okay, Talia is helping troubleshoot some of the video issues. I appreciate all of you being so patient. So there's our symptom. You can see we've drawn it for the duration that the patient reported. And we don't have any other symptoms to document, so now we can put that aside. The last thing we needed to document was our critical period. So we take our blue pencil now and we look at the symptom. So we first need to determine what is 90 days backwards from the symptom. The symptom onset is designated as March 16th. So we count 3 months or 90 days. We go, let's see, we're just after the 14-day mark. So we go 1, 2, 3. Or you can just physically count, which would be 12, 16. You can count on the VCA. So 1, 2, 3, or you can just count. So what we're going to do now is we draw our anchor point. This is the 90-day mark. This is the maximum duration of the incubation period. And so now what we're going to do is under that history line, you just draw yourself a nice blue line until up to the date of treatment. And as Summer was asking in the chat, the reason why we go up to the date of treatment is because the patient is considered infectious while a chancre is present. So until they receive penicillin and have been adequately treated, they are considered infectious. Now that we have our anchor point here, we can see our time period. This is the time period in which we believe Carmela was exposed to syphilis. I'll bring that up closer for you all so that you can see. And now we need to add our 10-day and our 21-day marks. So remember, 10 days is the minimum amount of time Carmela could have been exposed and developed a chancre. 10 days from 3/16 would be 3/6. So that's going to come just before the 7-day mark. And we draw our triangle facing out, or facing the opposite direction of the 90-day one. And then we need to do our 21-day. So we count back an additional 11 days, which will take us to 2/23. So that's going to be right about this area here. It doesn't need to be exact on a VCA. You're not going to get them exact because of the space is so scrunched. As long as you're in the general area, it will be fine. What I often do myself is I will write the dates so that way I can constantly keep in mind what my incubation period is. So this would have been 12/16. This would have been 2/23. This would have been 3/6. You don't have to do that stuff, but if it helps you visualize where those triangles should be, please do it. So this is our critical period. We've documented our symptoms. The last fact that we're supposed to plot on this VCA is sexual exposure information. At this point in time, we have not interviewed Carmela yet, so we don't know if she has sexual partners we need to put on the VCA. So let's review what we have done. You have now plotted your original patient on a VCA. Sometimes, if you don't have sexual partner, this will be all you do on a VCA. And I hope that was way less intimidating than what your partner services modules make it out to be. I'm going to switch back over to my share screen, and we're going to look at the practice exercise. Does anybody have any questions about what we have done so far? Not seeing any chats pop up. All right. So continuing on, now that we have plotted the facts of our infection on our VCA, oh wait, there might be a question. We're going to get to that, Sharon. We're moving on to that next part. You are ahead of the game, my friend. All right. So a DIS calls Carmela for an interview on 3/31/22, 2 days after the lab results returned for positive syphilis. Carmela answers the phone and she was able to conduct an original interview with the DIS at that time. During the interview, Carmela reports one male sex partner to the DIS. Let's review the information. So we gathered our foundation from Carmela. She reports one partner in the interview period, and the interview period for primary syphilis is 4 months and 1 week. We get that interview period from adding the maximum durations of the incubation period and the maximum durations of an untreated chancre. Carmela reports that she has oral sex, both giving and receiving, and she has vaginal sex with her male partner. Carmela reports that she has sex at home or in hotels when she travels. She gave us the name of her partner, and that is Johannes York. She reports her first sexual exposure, or her FSE, as January 1st, 2018. She reports her last sexual exposure, or LSE, with Johannes as 3/14/2022. They have sex approximately 2 to 3 times per week, so this would be their frequency. She reports that they have vaginal and oral sex. She tells us that Johannes and she live together. He can be reached by cell phone. He works at the Great Harvest Bread Company, and he uses Facebook and Instagram, and they met each other through friends. Carmela lets us know that she doesn't have any social contacts or associates that we could pursue at this time for clustering. And then she tells us that Johannes is a white male who's about 6 foot. He's blonde with brown eyes. His hair is very short. And then she notes some specific characteristics about him that would help us identify him in the field. So the partner was notified by the DIS to come into the STD clinic for testing and preventative treatment. The partner comes to the STD clinic on 4/6/2022. Review the labs and treatments below. So Johannes was tested and he had an RPR of 1 to 256. He had a positive EIA and he received Bistillin that day. Johannes also presented to the STD clinic with a palmar plantar rash that he reported having last 25 days at that time period. Our next exercise is going to be, do we need to plot this partner on the VCA? And if yes, we're going to complete that now. We should plot the facts of the case, the exposure dates, and do all the appropriate labeling. So my question for you all is, do we need to put Johannes on this VCA and why?
Is there any reason we wouldn't?
You tell me. Is there a reason why you would not plot the partner?
Well, he's her sexual partner, so I'm thinking we do need to plot him.
You are absolutely correct, Ms. Sharon. So he is the sexual partner. And Cecilia has also said he might be the source and he has secondary syphilis. So you all are correct. We do need to put Johannes on our VCA because he is a sexual partner and he has tested positive for syphilis. That is the key designation here on a VCA. We only put partners who have tested positive for syphilis on a VCA. If we have sex partners who are negative, we do not plot them on a VCA because they are not in the disease network. So I'm going to stop sharing my screen and we're going to switch back to video. You may need to re-pin me. Hopefully you won't have to. So just to confirm, we have Carmela on here. We have all of our good information. And now we're going to do the same thing for Johannes. So we have our black pen here now. And we go to this first section here labeled partner. So if you notice, it says patient and then partner. So we're going to come here, and this is where we write Johannes's name. And Johannes was a health department referred partner, meaning the DIS notified him of his exposure. So we're going to write health dep, referred, or whatever variation you would like to put there. We already have our months of the year, so we don't need to add any of that. And now we need to plot what we know about Johannes. At this point in time, we have not conducted an interview with Johannes yet. So we're only going to plot what we know, which is his syphilis testing information. Johannes tested on 4/6. And so what we're going to do is we're going to come to 4/6 right here on Johannes's history section. So that would be the month of April. Day 6 would be right about here. We're going to make a big T-bar, nice and dark, so it stands out. We're going to write 4/6/22. Or I'm sorry, yes, this is 22. Then on the left side of the T-bar, if you recall, we're going to put the stage of syphilis. And Johannes presented with a palmar plantar rash, which we know to be secondary syphilis, as Cecilia mentioned. So we're going to write 7/20 for secondary syphilis. Then we're going to document the syphilis information as we know it. He had an RPR of 1 to 256. He had a positive EIA, and he received BIC 2.4 times 1. At this time, this is all we know. So if we look here, we can see there's our basic medical information for Johannes. So he's our health department referred partner, and we have our T-bar so far. Since we plotted what we know about his medical information, now we are going to get our red pencil and we're going to document Johannes's symptoms. Johannes presented to the clinic with a palmar plantar rash that he reported having lasted for 25 days at the time of his visit. This would make the onset of the rash around March 12th. So we are going to start our red box here. We're going to find March 12th, which will be right about here. And we are going to draw our symptom box. And then we're going to put PP rash. Palmar plantar rash. So you all see that there. The rash lasting 25 days as reported by the patient. The next thing we need to do is we need to put Johannes's critical period on here. So we go to our blue pencil, and the critical period for secondary syphilis is 8 months and 1 week. So that means for 8 months and 1 week, we go backwards to July 15th of the previous year. And if you remember, 8 months and 1 week comes from adding the maximum durations of the incubation period, an untreated chancre, the latency period, and an untreated body rash. So because this goes beyond what our it goes right here actually. So we can come to July, and July 15th would be right about here. Hopefully you all can see that, you can. And then we make our blue line and we draw it all the way down. And this is the time period in which Johannes could have been exposed to syphilis, developed a chancre, went through a latency period, and then got a palmar plantar rash, assuming he went through the maximum durations of everything.
Emily,
Okay.
got a quick question in the chat, and also would you mind, yep, perfect. So Sharon asked if you can go over how you got that 8-month period for secondary again.
I sure can, yeah. Let me go back to our presentation. Okay. So let's come back here. Here we go. Thanks a little bit. So Sharon, for your question, how did we come to that 8 months and 1 week? So what we did was we added the maximum duration of the incubation period, the maximum duration of an untreated primary chancre, the maximum duration of a latency period, and the maximum duration of untreated secondary symptoms. This gives us 8 months and 1 week. Might be easier to see it this way in this chart down here. So if we add up all of these maximums, we get 8 months and 1 week. This represents the total amount of time that this person could have been exposed to syphilis and developed syphilis themselves. Does that answer your question?
Yeah, so you just add up all those maximums down there.
Yes, ma'am, we do.
Okay, gotcha.
On the VCA Pocket Assistant, it's saying for secondary syphilis begins 6.5 months prior to the onset of secondary symptoms as given by the patient.
Yes, Summer, that is a great question. So 6.5 months comes from adding the averages. 8 months and 1 week is preferred by the CDC. So that Pocket Assistant is a little outdated.
Gotcha. That's where
Yeah. Gail Bolin, when she was over the Department of STD Prevention at CDC, wanted disease intervention specialist staff to focus on that 8 months and 1 week in order to find the maximum number of people who could have been exposed to syphilis, or the maximum number of people that exposed our patient to syphilis. Some VIS, especially if they've been VIS for a long period of time, like myself, that 6.5 months will still stick in your mind. It took me quite some time to get used to the 8 months and 1 week, but as long as you remind yourself that it's just maximum durations versus average, we always want to do maximum in order to maximize our disease intervention capability. Does that answer everybody's concern or question about the 6.5 months? Okay, great, perfect. All right, great questions, everybody. I really appreciate your participation. So I'm going to give you a close-up of what this looks like now. So we have Johannes's critical period listed here. So this gives us a visual of when Johannes could have been exposed to syphilis. The last thing we need to do now that we have a sex partner on our VCA is add our exposure dates. So we're going to use our green pencil for this. And if you can see here, this line here, here we go. This line here and this line here, the one right above medical history for Johannes, this is where we're going to be documenting sexual exposure. So the two partners report that their last sexual exposure to each other was on 3/14/22. So we're going to come, this line represents Carmela. So we're going to find last sexual exposure. We're going to draw a green arrow down. And then Johannes reports the same. Now, you may have partners and original patients who report different exposure periods. That's fine. You just document what each partner has said. Thankfully, we live in an ideal public health world in this scenario, and our two partners reported the same exposure dates. So it's going to make our life a little bit easier. You can see I'm writing last sexual exposure, 3/14. And then what I'm going to do here, I'm going to have to turn it sideways so that I can color in. But what I'm going to do is I'm going to color all the way back. And typically we use dotted lines here. And they report that their first sexual exposure was back in 2014. So we're going to color this line all the way back, since the date of time precedes our chart. And we can just draw like a little arrow, and then you can write that first sexual exposure was in January of 2014. So that's what it looks like for Johannes. And since they report the same sexual exposure, we're going to do the same for Carmela. So we're going to just write 1/1/14. Sorry, I got to turn it sideways so I can color here. Then we just color in this line. And using a nice bold color for sexual exposure will aid us when we're trying to figure out source spread. And you'll see here in just a little bit how we're going to be using this visualization of sexual exposure to make decisions about who gave syphilis to who. So this is what a VCA looks like when you have plotted the facts of a case. So we have all of our pertinent medical information, and we have our critical periods and our sexual exposures. I think we had one more question pop up. Let me open up the chat. Cecilia asks, for Carmela, we use the incubation period maximum duration. And she's asking, when would we use the primary syphilis maximum period of 5 weeks? So Cecilia, that 5 weeks refers to how long an untreated chancre can last. For a person in primary syphilis, like our client Carmela, we really need to focus on the incubation period. She came to us with an active lesion, and so we don't necessarily need to worry about how long her lesion is going to last, because we need to focus on this time period here. We know for a fact that people develop a chancre within 90 days of being exposed. And so this is really when we need to figure out who was Carmela having sex with. So that's why we use the incubation period here. We really utilize the maximum duration of a primary chancre when we're trying to get interview periods nailed down for primary syphilis or for secondary syphilis, as we saw on our chart. So that does come into play, but we don't necessarily need to use it for our patient here. Does that make sense? Okay, thank you, Cecilia. I appreciate you confirming. Does anybody have any questions before we move on to part 2 of this exercise? Is all of this making sense to you? No question is a bad question. I'm here to teach you because I want you to know this critical skill inside and out. Okay, I'm not seeing anything come up for the moment, so I'm going to share my screen. We're going to move on to exercise 2. So if you would like to go ahead and open up exercise 2, actually, we're going to go back to exercise 1 because I forgot there's some questions I want to ask you all. Okay, so based on what we have so far, and we're not going to spend a whole bunch of time on this because I want to be able to finish out the exercises today. We've got about 20 minutes left. So based on what we know so far, are there any missing gaps? Or are there any missing information or gaps of information in the case? What are your inferences so far about source spread analysis? And what evidence do you have to support that claim? How does the information that you've gathered here gonna inform your re-interview with your original patient? And what next steps are we gonna take as a DIS? So you may unmute, you may put in the chat, whatever you are most comfortable with. I just want to get some critical thought from you guys and see what are you thinking right now about this case.
Somebody is not telling a partner, and probably Johannes, because it looks like he had syphilis longer than Carmela did.
That's a really good inference, Sharon.
Primary.
Yeah, I agree with you. So it does seem like there's another partner in here somewhere. Does anybody else have any additional thoughts? What do you think so far about this case? Fedeline says, who infected Johannes? He might be a source. That is a great question we should be asking ourselves. So I would count that as one of our priority actions next is, who is Johannes' source? He already has a palmar plantar rash. And what we know with the natural history of syphilis, it looks like there's somebody else involved in this situation. Vivian is asking, they have primary and secondary symptoms at the same time. So Vivian, sometimes people can have primary and secondary symptoms in one person at the same time. It doesn't happen often. We mostly see that in people who are living with HIV unsuppressed or other complicated medical issues, but somebody can develop a chancre and have a body rash at the same time. It's also a good question to ask yourself. The partner has a body rash and our original patient has a lesion. So we need to do some more digging into that. LaShandra asked, what happens if we can't get the info from Johannes? That's a great question. So if Johannes refused our interview, we're kind of stuck at the moment. We might be able to convince him to share information. Since he has a female partner who has the ability to become pregnant, we might want to convince him to share partner information and inform him of the risk of congenital syphilis to his girlfriend. So we can use our STD motivators or CHART, C-H-A-R-T. So we can remind Johannes about the complications, the risk of HIV infection, the asymptomatic nature of syphilis, the reinfection risk, and how syphilis is transmitted between people. So we can motivate him to give us information by confronting him with what we know about syphilis. And Dashani said, well, we haven't interviewed Johannes yet, so we're unsure about his P1s. You're right about that. We haven't interviewed him yet, so he might give us some good info. And Thomas said, we should try for a re-interview. Thomas, I like that train of thought. I think that might be a good task to do for Carmela. All right, you all, I really, really appreciate your participation. So now we're going to move on to exercise 2. I'm going to share my screen again. And Frederline also says we need to re-eye Carmela. You guys are on the right track here. Those are all the things that I would recommend to my own DIS team. So let me make this bigger. There we go. All right, friends, now we're moving on to exercise 2. So Johannes was tested positive for syphilis on 4/6/22. He comes into the STD clinic for testing and preventative treatment after being notified by a disease intervention specialist at the county health department that he may have been exposed to syphilis. During that appointment, Johannes also had a negative HIV-1 antibody test, a negative urine chlamydia gonorrhea NAT testing. Johannes presented to the STD clinic with a rash on his hands and feet. When the rash was pointed out to Johannes, he said he had noticed it, but he thought it was related to his seasonal allergies. He had not tried any over-the-counter medications to deal with it. Johannes told us that the rash had been present for about 25 days. The physician orders Johannes to receive Bicillin that day and diagnoses him with secondary syphilis based on his symptom presentation and known exposure. He receives Bicillin 2.4 million units times 1 dose on 4/6/22. He schedules a future appointment to have his RPR drawn again in 3 months. Upon further review of Johannes's STD history, it is discovered that he previously reports having sex with both men and women and was last tested in August of 2021. At that time, Johannes was negative for chlamydia and gonorrhea, and he had urine and rectal samples done. He had a negative HIV-1 antibody test, and he had a negative RPR. His reason for testing on August 10th was listed as routine screening of man who has sex with men. At that visit, he reported having oral and vaginal sex with one female partner and oral and anal sex with male partners. He reports living at home with his girlfriend, and he feels safe at home, and he reports his girlfriend is not pregnant. So let's review Johannes's VCA. What do we need to add to it given the information we have discovered during our pre-interview analysis? So going back here, what information should we add to our VCA? Dashani says the non-reactive RPR. I completely agree with that. So since that was in August, we're going to come back to August. And my writing's kind of in the way here, but I'm going to do my best. So we're going to draw a little arrow. I'll bring it out to the side over here. And he had a non-reactive RPR on 8/21/21. He also had negative HIV. He had negative chlamydia, gonorrhea. So we're going to document that relevant medical history. And Lori said HIV results. Great job, Lori. That's absolutely correct. So this is relevant to our STD history. Can anybody tell me why knowing that non-reactive RPR matters in this case? Thomas
It
says
tells
helps
us
with
he
the
got
timeline.
it from somebody he had sex with between this date and his first incubation.
You are absolutely correct. So Thomas and Sarah and Ernesto, all of you had said, and Miss Sharon, you have all said it narrows down the time of exposure. It shortens the incubation period. Absolutely correct, guys. This shortens the time frame in which we're looking for exposures that Johannes may have had. Since we know he was definitely negative for syphilis in August, which means he had no syphilis in the time period beforehand, that means Johannes was exposed after August 21st up until our date of treatment, because right now we're not sure when he may have acquired syphilis. So it shortens our interview period by a little bit. And so we can focus on the partners that Johannes had from August all the way on. Great job. All right. And Thomas says it also helps with ghosting. Dashani says it can help ghost a primary lesion. Absolutely. You guys are right on the money today. All right. So going back to our exercise 2, let me bring that back up for you all. Vivian is asking, what was the reason he was tested? Did he have signs and symptoms at that time? So per our exercise, what we read was that Johannes was notified by the DIS to come in. So that's why he was tested, and he did have his palmar plantar rash at the time of testing. All right, so now Johannes returns to the clinic and speaks to the DIS on 4/11/22, 4 days after his positive labs have resulted. During the interview, Johannes becomes distraught. He has been in a relationship for 3 years with his girlfriend, so the news of testing positive for syphilis is an upset for him. He is initially hesitant to discuss his sexual partners. However, after you confront him about his sexual partners from August and inform him of the risk of congenital syphilis, he begins to give you information. And we can look at our foundation. Johannes reports 3 sexual partners within the interview period. He participates in oral sex, both giving and receiving. He has anal sex, both insertive and receptive. And he also has vaginal sex with his female partners. He has sex at home, hotels, in cars, and bars. And Thomas is asking, what was the reason for testing from August of 2021? In our exercise, he was tested at that time for, let me move the chat here, routine screening. So he was known as the man who has sex with men to his provider. And so his provider was conducting an annual screening for syphilis. Again, this is an ideal public health world. We wish everybody was like that. You guys are asking wonderful questions. I really appreciate your time. So Johannes has given us 2 additional partners besides Carmela. We have Ryan Williams, who Johannes has sex with at least twice per week, but he last had sex with in December. And he has another partner, Anthony Moore, who he has sex with less frequently. He met Ryan at a bar, and he met Anthony on Grindr. And then we have our physical descriptions of our 2 male partners here. Johannes was very adamant that Carmela could not know about his additional sex partners, who both are male. You reassured him that legally you cannot tell Carmela his private health information, but you did take the opportunity to remind him that he was putting Carmela at risk by not informing her of his additional sex partners. You asked Johannes if he remembers seeing any sores on his partner and showed him the CDC picture cards. Johannes explains that his longtime sex partner, Ryan, had a sore on his mouth around Christmas the last time they had sex. Another thing you can do as a DIS is you can trigger people to remember things by holidays, birthdays, special events. Typically, people will have sex on their birthdays, around Christmas, for Valentine's Day, et cetera, et cetera. So always take the opportunity to say, who did you have sex with around Christmas time? Or who did you have sex with around Valentine's Day? People will remember those dates because they were specifically seeking out sex around that time. Johannes remembers this because Ryan wouldn't let him kiss him, stating it was a cold sore. But Ryan did perform oral sex on Johannes while the sore was present. Johannes did not recall any other partners with symptoms. You call the two male partners the next day and inform them of their exposure to syphilis. They both agree to come to the STD clinic to be screened and to receive preventative treatment. And we're going to look at their lab below. So Ryan had a positive RPR of 1-64. He had a positive EIA. He received bicillin that day, and he had no active signs and symptoms of syphilis at that time. We already have Carmela's information since she was previously tested, and his second partner, Anthony, had a non-reactive RPR, and he refused treatment at that time. He also had no active signs and symptoms. So our last exercise of the afternoon, which partners need to be added to the VCA and why? Scrolling up, Thomas. Lori says we need to add Ryan. Frederline says we need to add both. Mary, Sharon say Ryan. Ernesto says both. Thomas says no to Anthony, and Cecilia says Ryan. So it seems like the general consensus is that we need to add Ryan to the VCA. Why is that? Exactly. Cecilia says positive serology. Sharon says Ryan is positive, Anthony is not. That's correct. Ryan is positive, so he's part of this disease network. Anthony has non-reactive testing at this time, so therefore we do not add him to the VCA right now. All right, so we have that covered. The next question before we add Ryan to the VCA, at this point in time, because Ryan had no signs and symptoms, how are we going to stage Ryan's syphilis case and why? Cecilia says 7:30 or early syphilis. Frederline says 7:30. Tanya says 7:30. All right, the general consensus, Scott and Ernesto also agree it is a 7:30. And why is it a 7:30, you guys? Lori says it's a 7:55. Okay. Thomas says no signs and symptoms. Sharon says 7:30 with no active signs and symptoms. Great job. Okay. Yes, Frederline is correct. Contact to an early case. Dashanice, you got it. Correct. Cecilia, way to go. Exactly, Vivian. So Ryan is connected to a 7:20. That makes Ryan a 7:30. He is connected to an early case. Great job, folks. Okay, so the next thing we're going to do, I'm going to try my best to keep us on time here, but you all are being so awesome and participating. I love it. So now we're going to repeat this process and we're going to add Ryan to this VCA. Now that we're having more than one partner, we need to indicate who is a sex partner to who. So what we need to do is we need to draw an arrow from Carmela to Johannes. You can use these little brackets over here. I personally don't like those little brackets, so I like to just draw an arrow. And now we need to draw an arrow from Johannes to Ryan to indicate that Johannes and Ryan are sex partners. And so we're going to write Ryan here. Ryan's reason for exam was he was a health department referred partner. The DIS called him and brought him in for testing. I'm going to just keep that short and write health depth there. So you guys can see that. We have our arrows indicating who our sex partners are. And again, only positive partners go on a VCA. Even though Carmela and Ryan are not sex partners, they are part of the same disease network by way of Johannes. And so now we're going to add in our medical information. So Ryan, let me pull back up my facts of my case here. Ryan was tested on 4/15, so we're going to come down to April. We're going to come down to Ryan's line over here. Day 15 will be right about here. Say 4/15/22. At this time, Ryan is a 730. And so we know he has an RPR of 1/64. Positive EIA. We are probably going to go over by a few minutes. I hope you all can stay. If you cannot, please watch the rest of this recording. We also have BIC 2.4. So that's what we know about Ryan. We don't have any other additional information about Ryan at this time. So now what we need to do is we would document symptoms, but Ryan does not have any symptoms. So we're not going to draw any red red rectangles here. We will grab our blue pencil next, and we will do our critical period for Ryan, which is 1 year. For 730s and 755s, your critical period is 1 year. And so you're going to just draw a blue line all the way down. So you can extend that out for yourself and say it goes back to 4/15/21. Okay, so now we have done that. We add our sexual exposure information with our green pencil. And they report their sexual exposure, well, as we know it from Johannes at this point in time. This will be the line that refers to Johannes. This is the line that refers to Ryan. They first had sex back in 2014. And so we're going to draw that all the way out, kind of like we did for this one here. And we'll start it back here. So 1/1/14. So they've been having sex since 2014. And then their last sexual exposure was reported. We write first sexual exposure here. Their last sexual exposure was reported on 12/27. So if we come to December, we come down to about day 27, it's going to end right here. So we can say last sexual exposure, 12/27. And forgive me, I need to turn sideways. And then we're just going to color in our sexual exposure information. Okay. So now that we have all the facts of our case plotted, what all do you think we need to do now? What are the next steps in this case? What are your inferences? Have we done enough to determine who is a source and who is a spread yet? We're saying we need to interview Ryan. I absolutely agree with that. We need to call Ryan and speak to him. And we need to talk to him. Like I said, I'm probably going to go over, forgive me. If you can't stay for the remainder of this, I promise I only need like 10 more minutes of your time. That's fine. But please do watch the rest of this recording if you have to hop off at this point in time. So we need to figure out who is the source and who is the spread in our scenario. Part of the ways we can do that is by using ghosting. So Sharon, we're going to touch on one of the questions you had earlier. And we need our orange pencil. So you're going to grab your orange colored pencil. We said earlier that ghosting was the technique that we use to determine who is a source and who is a spread. This is going to give us the most educated guess as to how disease was transmitted between these individuals in this network. We have somebody who has an active lesion. And if you remember our ghosting hierarchy, we are going to get the best story of transmission by starting with an existing primary lesion. Carmela has an existing primary lesion. We need to figure out who gave syphilis to who. So one of the first things that we're going to do is we're going to say, okay, what if Carmela gave syphilis to Johannes? So Carmela has an active lesion. We go in the middle of her lesion and we're going to draw a dotted orange line. This is why VCAs get complicated because you have to write on top of everything. We're going to draw an orange line down from the center of that lesion. From the center of this lesion, we are going to draw we're going to count 3 weeks. And what we're saying is that this lesion gave Johannes syphilis. And we're going to see if that makes sense here in a moment. So we need to draw a little orange triangle here. So if you guys can see, we have started at the center of Carmela's lesion, drawn a little orange triangle on Johannes. We're saying that that is the inoculation point of Johannes. So we're going to count 3 weeks from this inoculation point to represent an average incubation period of 21 days. So we go 1, 2, 3. And although you can't see it, I'm using the little slashes to count. So each slash represents 1 week. So 1, 2, 3. It doesn't have to be exact. You're going to draw a dotted line. So again, I have to write over what I did, but you see my tiny little dotted line 3 weeks after our inoculation point. We're going to count 3 more weeks to represent a 3-week lesion. This is the average duration of a lesion. We are using our basic assumptions here. We are assuming that there was a 3-week incubation period, 1, 2, 3, and that Johannes will have a 3-week lesion. So we go 1, 2, 3, be right about here. This is called a spread lesion, SPLX. What you are saying by ghosting this spread lesion, you are saying that Carmela, the person with an active lesion, gave syphilis to Johannes, and we are projecting that this is when Johannes would have had a lesion. Does this make sense for our story?
No, because he has secondary symptoms.
Exactly.
He's already way past primary.
Exactly. You guys are right on it. So what this tells us is that there is, oops, sorry, y'all. What this tells us is that there is no way Carmela is a source. What we have done here is called ghosting a spread. So a spread lesion. We were trying to tell a story that Carmela was Johannes's source. And what we know from seeing this outlined, it's not true. So now what we need to try to determine is, did Johannes give syphilis to Carmela? Since we have ruled out that Carmela is not the source of infection. So what we need to do is we start at Carmela's inoculation point. This is day 21. This is when we assume Carmela was inoculated by her source. So we are going to draw another dotted line down to Johannes. And now we have a center right here. This is going to be the center of Johannes's lesion. Because we're using our basic assumptions and lesions last on average 3 weeks, we are going to make this box a 3-week box. So if this is on the center, we go 1.5. So there's 1.5 weeks. And we go 1.5. And then we do another dotted line. This is called a source lesion, or SOLX. So we use our basic assumptions and what we know about the natural history of syphilis. And we say, we project, this is the time frame that Johannes had a lesion. Does this make sense with our story? What do you guys think? Is Johannes a source for Carmela?
Makes way more sense.
Seeing a lot of yeses, absolutely. I totally agree with you all. We can verify that this story makes sense because we can see our visualization of sexual exposure. Our ghosted lesion occurs in a time period when they were having sex with each other. So it makes sense that if Johannes had a lesion here, he would have infected Carmela, and Carmela developed her lesion approximately 30 days later, about 21 to 30 days later. So for right now, this story makes sense to us. It sounds like Carmela received syphilis from Johannes. So at this point in time, since we're really certain about that, what we can do is you see this left-hand or this right side column here. This is called your source spread analysis column. When you are done with your source spread analysis, you can make some designations here. SO means source, SP means spread. And remember, source means somebody who was infected and gave syphilis to an uninfected person. Spread means somebody who was uninfected and received syphilis from an infected patient. We know that Carmela is a spread from Johannes. Right now, we know that Johannes is a source to Carmela. And so what we can do now, because Ryan doesn't have any symptoms, we don't really know anything about him yet. We haven't interviewed him. That's next on our list, though, for our plan of action. But what we can do is we can take this ghosted source lesion, and then we can ghost another lesion onto Ryan. Now, if you remember our hierarchy, a ghosted lesion is our third best choice. But right now, it's all we have. And what we do recall is that Johannes thinks Ryan had a sore on his mouth around the last time they had sex with each other. We don't know for sure, though, because we haven't talked to Ryan himself yet. So for right now, we need to make our best guess. So we're going to repeat the same process we just did. So let's say that this is Johannes's lesion. We believe he gave syphilis to Ryan. So what we're going to do is we come down, we draw our dotted line, we start at the center of that lesion, we draw our dotted line, and then we make a little dot here just for ourselves, our little triangle. This is at the point we expect Ryan may have been inoculated. So we go 1, 2, 3. There's our first line. Then we go 1, 2, 3. There's our second line. So we have created a spread lesion. We believe at this point, Johannes had a lesion here. He gave syphilis to Ryan, and then Ryan developed a lesion 3 weeks after being exposed to Johannes. Now let's take a close look at this. Does this make sense?
No, because they didn't have sex at that time period.
Exactly, Ms. Sharon. They did not have sexual exposures. So if this is the point in time that Johannes had a sore on his penis, there is no way that he could have given syphilis to Ryan because there are no sexual exposures. Great job. So since we have disproven the spread theory, we now need to try to see, is Ryan the source to Johannes? So what we do is we come to this little incubation or this little inoculation point here. I'm sorry, not this inoculation point. we need to go to Johannes's inoculate or ghosted lesion and count back 3 weeks. So 1, 2, 3. Johannes had a guesstimated inoculation point right here for this lesion. So we come down here, draw our dotted line. And then we, excuse me, y'all, let me grab a sip of water real quick. Thank you, so sorry about that. And so we again go make our center line here. And we say 1.5 weeks. And then we say 1.5 weeks. And we call this our source lesion. So when we look at this, according to our ghosted lesion, we have estimated that Ryan may have had a lesion in January. Does this make sense for our story?
Yeah, he could have had a lesion, but it would have started, 10 days before that when they did have sex around Christmas.
Yes, I love that you're critically thinking, Sharon. So you're absolutely right. That was my thought as well. If one of my DIS were to bring a case like this to me and they said, you know what, I do think Ryan is a source, I would be apt to agree with them. So although we do have some space, oh gosh, I'm not even showing you guys the right thing. Here we go. Although we do have some space and we don't necessarily have an overlap of our sexual exposures, this is close enough, their last sexual exposure being at the end of December and Ryan having, or Ryan projected to having a lesion around that time frame. This is close enough and a very educated guess that I would accept a DIS telling me that they believe Ryan is the source. I accept that margin of error because we are using the third most best option, which is a ghosted lesion. So these are all just educated guesses, but it makes sense with the disease history that we know so far. Johannes also reports seeing a lesion on Ryan's mouth around that time. So it's very possible that Ryan did have that lesion back in December, early January, etc. Okay, that is the end of our story as we know it. So for now, we have agreed that Johannes is a spread from Ryan, and Ryan is a source to Johannes. Now you all are correct. Our next thing would be to interview Ryan and see what he's been up to, what sex partners he has. And if he has any positive sex partners, we continue to add them to this VCA. That is all I have for you all. I truly appreciate you spending this time with me. Thank you for letting me go 15 minutes over and taking up some of your valuable time. Are there any last minute questions, concerns that I can address for you all?
Thank you so much, Emily. And while folks have any last minute questions that they put in the chat, I went ahead and launched our brief evaluation. So feel free to let us know what you thought of today's session. But everyone, please join me in thanking Emily. This was such a fantastic training. And we're really grateful for the time that you took to put this together and share with us today, Emily. So thank you so much. And like I said at the beginning, I'll be sending the recording to you all. So if you missed something or want to go back and check again, you will be able to.
Thanks, everybody. If you have any questions for me or if you need clarification on anything I've written or provided, please don't hesitate to email me. I am more than happy to have a one-on-one with you, to talk directly with you. My email will be on the slide deck and it's also on the exercises too. So please contact me if you need anything.
Great. Thank you again so much, Emily. And I hope everyone has a great rest of their afternoon. All right. I'll be in touch soon with the recording. Thanks again, everyone.